Okay, thanks very much, Callum. Thanks to everybody who's here today. I'm really the filler. Okay, so most of the work is done by my two colleagues, so I'm just going to take probably 5 or 10 minutes of your time just to show you a little bit about the imaging that we're doing in order to try and identify the scar non-invasively. And the bottom line is we're mainly using CT, and that may not seem like a very logical choice to many of you in the audience, particularly as I'm an MRI person. And there are some challenges with doing this by CT, but there are reasons why MRI is difficult, particularly the artifacts that we would get from both the leads and the can often make it very difficult to get useful pictures. So we've been doing CT scar imaging for quite a while, and I'm going to show you a few examples. So this, of course, is what we would like CT scar imaging to look like. It doesn't. This is MRI, and you can see that normal myocardium is completely black. You can see that the blood pool is grey, and the area of scar is white. So it's beautiful. You can easily tell what's what, and that's what we would like CT to look like. And it's dead simple. You give contrast, you wait 10 minutes, and then you take some pictures. Unfortunately, it's not as easy as that for CT. But the reason it works, either for CT or MR, is that there's a differential wash-in and wash-out rate of contrast between normal myocardium, healthy myocardium, and areas of scar. So scarred myocardium, it's slower for contrast to wash in, and once the contrast is there, it's slower for contrast to wash out again. And one of the nice things about MRI is that we can play some clever sequence tricks that allow us to choose an inversion time when normal myocardium is dark. If that sentence doesn't mean anything to you, it doesn't matter. The point is that with MRI we can cheat, and we can make normal tissue completely black in order to make scar stand out. And the challenge with CT is that we can't do that. But iodine is a contrast agent that behaves in just the same way as gadolinium, and so it does work for imaging scar. And this was shown almost 40 years ago by Charlie Higgins from the San Francisco group in a dog model of myocardial infarction, and these were the high-quality CT images on the left and the matching histopathology on the right. And of course, this is your best-case scenario. This is an acute infarct. It's a coronary tied off. It's full of edema. It's sucks up iodine. This is not what we're dealing with. We're dealing with chronic thin scar, and it's a much greater challenge than this sort of thing. And partly because of this, it was almost 25 years after this was published before anybody tried to do this again. Again, this is from the original paper. This is what CT looked like in 1982, and there's the matching histopathology. But one of the reasons that people have not really been very keen to pursue scar imaging by CT, apart from dose and perceived difficulty, is this problem with getting the contrast ratios right between scar and normal tissue and between scar and blood pool. And so you can see here that ideally you want to image, if you want to get a good contrast definition between normal and infarct, you want to image about 3 hours after you've put them on the CT table. And my CT techs are fairly tolerant, but 3 hours is something that they won't put up with. So actually, we usually image people about 10 minutes after we've given contrast. And you can see the ratio of contrast in infarct to scar is only about 2 to 1 at that point. Even more difficult is the relationship between the uptake into the scar and what's in the blood pool. So we don't have this mechanism really for suppressing signal from normal myocardium. So what we're always trying to do is see scar which is a little bit brighter than all the normal myocardium next to it. And that's the bit that's challenging. So as I say, for about 30 years after the Higgins paper, nobody bothered. And then Koyama in Japan decided to have another go and tweaked the protocols a bit and used a slow infusion of iodine, which I think works better, and got sort of pictures that weren't too bad. And this is the sort of thing that we get if you concentrate on this middle panel. Here is the scar, and you can see what I mean, that this actually is not too bad. You can see a reasonable difference between normal, which is sort of grey white, and scar, which is completely white. But you can see how there's no discrimination at all between the blood pool and the scar. So you really have to, your eye has to really trace the contour of the ventricle to work out where the scar is. And so it's just not quite as easy. I wanted to show you a couple examples of cases that we've done at the Heart Institute to prove that it can be done and it does work. And I've fiddled a little bit with the windowing here just to emphasize it. This is a hypertrophed patient who had a VF arrest, and this is an area of dense scarring in the anteroseptum. You can see on the volume rendered image. But you see this here, this is all artifact that comes from the pacing wire, from the shock lead. And so just as we get problems in MRI with leads, we also get problems with CT. And the problem with this in particular is that you get artifact along the inferior wall of the ventricle. And of course, every case that Callum sends me has a right coronary artery infarct, and so there's always terrible artifact in that area. But that's what we have to deal with. This is a comparison of a case of myocarditis. I wanted to show the MRI on the left. You can see the subepicardial scar in white here. It's the same patient with CT. So it's not as pretty, but it's definitely diagnostic. There's no doubt about it. Here's an LV arrhythmogenic cardiomyopathy. Here's the scarring on the MRI. A little bit harder here, but you can still see that there's a subepicardial scarring here on the CT scan. And another pathology, cardiac sarcoid. On the MRI, the whole thing seems to be involved. There's white everywhere, including white in the RV and some of the RV trabeculations. On the CT, this is not as good, this case. We can see something going on in the septum, but really we don't see anything going on in the right ventricle at all. So there are plenty of challenges, and the right ventricular scar imaging by CT really isn't possible at the moment. Anyhow, so when Callum said to me, can we use this CT scar imaging then for the VT stuff? I said, yeah, no bother, pal, we can do that for you. And so we did the first case, and it was a disaster. This was the very first one. He was a very big guy, as I remember. He had a defib in, obviously, but terrible artifact everywhere. And I looked at these images, and I played with them for about 2 hours, and I thought, I can't see any scar anywhere. What am I going to tell Callum? This isn't a good advert for CT scar imaging. But fortunately, we get additional information from CT that goes above and beyond just trying to see the scar itself. So not only these images are required about 5 minutes after the infusion of contrast, but we also acquire a data set that's performed in the arterial phase. And we can use some of that information to look at the relative iodine density in the heart. And when we create 3D maps to show where the iodine has been taken up, obviously normal myocardium in the arterial phase takes up contrast very rapidly, whereas the scarred areas don't show as much iodine. So this is a 3D model of the LV. This is the RV lead here. And anything that's sort of reddy green is pretty normal. This is the anterior wall of this patient. And then we flip it over and look at the inferior wall, and blue and purple is very abnormal. So these are all the scarred areas. So although in this case, the scar imaging itself didn't really work, to be honest, the iodine map from the arterial phase still gives us information about where the scar is likely to be. The other thing is that we acquire the arterial phase in the systolic portion of the cardiac cycle, and I do that deliberately because obviously thinned and scarred areas are not going to contract and thicken during systole in the same way that normal areas are. So when we look at the same patient again and we look at a polar plot of relative wall thickness, for those of you who may not be familiar with a polar plot, it's simply a way of mapping all the LV segments in a convenient way. So we look at these 3 segments. This is the anterior wall, basal, mid, distal. Here we've got the lateral wall, basal, mid, distal, inferior wall, septum. And what you see is green is normal, and the area that's blue is in the inferior wall, the apex, and the infralateral wall, suggesting that during systole, this area doesn't thicken up at all. So that matches quite well with what we see on the iodine mapping as well. Because this was our first patient and CT scar hadn't been terribly effective, we thought we should check to see with another modality to see whether we got agreement about the location of the scarring. This is a resting rubidium PET. This is another polar plot, and you can see that the inferior wall and the inferior lateral wall are densely scarred. Just for reference, that was the picture I showed you a moment ago from the thickening from the CT, and you can see there's actually a very good correlation between the 2 techniques. So one of the questions is, could we do this better? Because I think CT scar imaging is still a bit of a niche enterprise. This is some work that I did with Vijay Chawan when I was still in Toronto, and we tried using intracoronary delivery of contrast in order to see scar, because I think the problem is you give an intravenous injection, everything's just too diluted. What you really want to do is deliver the contrast in a concentrated form to the myocardium via the coronaries. And here are 3 examples, one which I think you probably struggle to see very much. I think this one I can convince you there's a large anterior scar. And this one I was very happy with. This one almost looks like an MRI. We have a grey blood pool, I've got nearly dark myocardium, and I've got a very well-defined scar. So I think there is some utility to giving intra-arterial contrast when you're struggling to see scar. Obviously it's more challenging, and all the potential concerns about moving a patient from the cath lab table to the CT scanner. This is This is a fourth case we did when I was still in Toronto, and this is actually an example where VJ took the data, and we created a 3D cast with the scar mapped on, and then managed to merge it and import it into Carto and use it as part of the procedure. And I don't understand these lovely coloured maps, but I'm told that the scar area here correlates pretty well with the electroanatomic findings. So that was my filling in between the two slices of cake. CT scar imaging isn't perfect, but I think it's probably good enough for what we're trying to do here. And I'll leave it at that and pass on to Graham.